So thank you again for having me back. I really appreciate it. So I get to talk to you about evidence-based management of sudden hearing loss. Okay, so I have no significant conflicts of interest, but I was the vice chair for the initial sudden hearing loss guidelines at the Academy, and I was chair for the clinical practice guidelines update on sudden hearing loss that was published in 2019. So let's talk about what is sudden sensorineural hearing loss. Okay, so sudden hearing loss is a rapid onset subjective sensation of hearing loss in one or both ears. If it's in both ears, it really does not fit the evidence that we're going to talk about now, because if it's in both ears, you really have to think about viral, bacterial issues. You have to think about autoimmune disease, and you have to think about trauma. So that's a different animal than when we're talking about unilateral sudden sensorineural hearing loss. And when somebody says to you, I can't hear, they're just saying they can't hear. It doesn't mean they have sensorineural or mixed or conductive, and that's really up to you to determine. So what we're going to talk about for the majority of the next time that we have together is sudden sensorineural hearing loss, which is a subset of sudden hearing loss, in that it is sensorineural in nature. It occurs within a 72-hour window, and it consists of a decrease in hearing affecting at least 3 consecutive frequencies. Now, that's the traditional definition, but we all know that in practice, we use these guidelines and we use these management tools to treat people whose hearing loss may not be as severe as detailed by this 30 dB and 3 consecutive frequencies. Idiopathic sudden hearing loss is sensorineural hearing loss for which a cause has not been identified despite adequate workup. So you can't just say it's idiopathic the first time you meet the patient. You have to know that it's idiopathic by ruling out most of the common things. So the incidence of sudden hearing loss is between 5 and 27 per 100,000 people in the United States, and it may be as high as 160 per 100,000. The US data may be underestimated, as individuals who experience mild sudden hearing loss or quick or spontaneous recovery will not enter the healthcare system. For most patients with sudden hearing loss, their medical journey often starts in the emergency room, in a walk-in or urgent care clinic, or at their primary care physician's office. And the numbers represent up to 60,000 patients annually in the United States. So idiopathic doesn't mean there isn't a cause. It means that we cannot identify the cause. So it could be due to cochlear ischemia. It could be due to a viral etiology, and the evidence for that is listed on the slide here. And it can be consistent. The histopathology shows that it can be more consistent with a viral or inflammatory, because in the one set of temporal bones we have by Shucknecht's lab of somebody who died within 24 hours of their sudden hearing loss, which is not a common event. We see hair cell loss, we see minimal ganglion cell loss, we see some atrophy in the stria, we see a lack of fibrosis. Maybe there's some inflammatory cochleitis, and there is no leukocytosis or hemorrhage that is seen. But these etiologies are not mutually exclusive. So viral insult can cause direct neural injury, direct vascular structure injury, and direct injury to the red blood cells. Viruses can also lead to inflammation that causes vascular insufficiency, and autoimmune disease can also lead to vasculitis with anti-endothelial cell antibodies. So the common link between all of these possible causes may be free radical or cellular stress factors. So as I said, there was a clinical practice guideline in 2012, and then there was an update in 2019. And the update is what I'm going to be discussing. It has 13 key action statements, and I want to go through them. But let's just remember what are clinical practice guidelines. So they are statements that include recommendations intended to optimize patient care. They're informed by a systematic review of the evidence. So similar to, let's say, a Cochrane type of systematic review. It's a really thorough systematic review and an assessment of benefits and harms of the treatment and alternative treatments. So they focus on quality improvement opportunities, they define actionable recommendations, and they also identify research needs. And there are some very nice resources if you want to start trying to accomplish a clinical practice guideline. It's a lot of work. They're updated every 5 years because we expect that the literature enhances or changes your current management at about every 5 years. So we want to keep the clinical practice guideline valid. What are they not? So they're not comprehensive management. So you still get to be the physician taking care of the patient. They're not intended to replace or supersede your clinical judgment about what's going on in the milieu of the patient, their environment, the presence or absence of COVID, for example. They're not reimbursement policies, which is much more important here in the United States, where reimbursement is an issue. I just had a phone call with some it's called a peer-to-peer review, where there's some guy with a medical degree at the other end of the phone working for the insurance company, who this particular individual did not know what a myringotomy was. So I don't think he was quite the peer that the patient needed. But the insurance companies are always looking not to pay. They're not performance measures, but you can draw performance measures from guidelines. So you can say, these are the key action statements of the guideline on sudden hearing loss. How many times, what percentage of the time did Dr. X, Dr. Chandrasekhar, act in accordance with the guidelines? That could be a performance measure, and it would say, how many times did she get an audiogram within X amount of time of onset of hearing loss? That could be a performance measure. How many times did she offer, blah, blah, blah. So you can pull that from there, knowing that in my documentation, I might say, I'm not giving this person oral steroids because they are brittle diabetic and there's a high risk to their diabetes management if I give them oral steroids. So all of that has to be included if you are developing performance measures. And they're not clinical consensus statements, which have much less evidence. They're mostly expert opinion. This is really based on as much evidence as we have to review. So this is a very nice thing that you can kind of get from otolaryngology head and neck surgery. It's the clinical practice guideline development manual, and it's very nice. If you read through it, you get a very good sense of how we develop these guidelines. So in this clinical practice guideline update group, these were the panelists, and you can see in the different colors that are not black, about half of the panel were not otolaryngologists. So we had an emergency room physician, we had a consumer representative from Consumers United for Evidence-Based Care, or CUE. We had a family physician represented, we had a neuroradiologist represented, we had an audiologist represented, and we had a neurologist represented. Within the otolaryngologists, 4 of us, indicated by the ear symbol, were otologists, and the others did general or non-otology otolaryngology. It's very important that we don't talk inside our own little silo, assuming that other people can understand or act on what we recommend. So having a diverse guideline like this is very important. So what does a key action statement look like? It'll have a statement like this one from the Bell's palsy guideline. It says clinicians should prescribe oral steroids within 72 hours of symptom onset for Bell's palsy patients 16 years and older. So that's our statement, and that guideline happened to be only for age 16 and older. It's a strong recommendation, so it tells you why. It immediately tells you that we either had evidence quality A or B with a preponderance of benefit over harm, because that's how you get over here to strong recommendation. And it'll tell you what that was based on. And then it includes some supporting text, and it tells you the evidence profile, including were there differences of opinion among the guideline panel as we talked through, to say, well, you know, maybe it's not 72 hours, maybe it's 7 days, etc. So we talk you through what we discussed. So we either make a strong recommendation or recommendation for or against. We say it's an option, that there's not enough data to recommend one way or the other, or we make no recommendation at all, which is kind of it's a cop-out. Like you really want to look at things that have enough data that you can really come up with some guidance for the clinician. So let's take a walk with the patient through their journey. So patient has sudden hearing loss. Now what do they do? So the first thing we should do when we see them, whether we are an otolaryngologist, otologist, family physician, emergency room physician, is we should determine, is this sudden sensory neural hearing loss or is it sudden conductive hearing loss? So the exclusion of conductive hearing loss is written in as the first key action statement of the update, and you absolutely should distinguish one from the other, because obviously the treatment trees are very different. How can you do this? You can do this with a simple tuning fork test, and because nobody apparently knows how to do Weber and Rennie tuning fork testing, there's a video for that. So there's a little video I made with now a colleague of mine. He was a resident of mine at the time. And so if you want to teach your primary care friends or your medical students how to do tuning fork tests, there's the video on YouTube. You can certainly access it. There was a very nice paper this weekend at COSM, at the American Otological Society meeting, at the Combined Otolaryngology Spring meeting, looking at using vibration from the mobile phone as a virtual visit tuning fork test. So I think there's some interesting ways we can try to distinguish whether we are able to see the patient or not. Why is this important? Because the earlier we take care of somebody with sudden sensory neural hearing loss, the more likely their chance of recovery. So at the House Ear Clinic in 1996, Bruce Fetterman, Jim Saunders, and other researchers looked at 837 patients, and they saw that if they were treated within 14 days and certainly within 28 days, about 50% improved, whereas if the treatment was delayed past 4 weeks, their chance of recovery was significantly less. Vijayendra looked in 2012 and found that if the treatment was instituted within 3 days, 78% had complete recovery. Again, Gallo looked at this in 2013 and felt that we had a window of opportunity, that he could not prove that 24 hours was better than 7 days. So we do have a little bit of time for the patient to decide they have a problem, access the healthcare system, and be properly triaged to come to see us. So we know that the window does not shut at 28 days, but we know that the window of opportunity for recovering hearing closes over time. So the shorter the duration between onset and institution of care, the better for the patient. This was a very nice paper that came out in 2017, and it looked at the problem that we face. So the mean days elapsed before treatment was 36 in this study, which is huge. So the difficulty is that once you're over a month afterwards, you're going to expect your outcomes to be poorer no matter what you do. One, the people who are going to get better on their own are not in that group. Two, the people who would respond to treatment, it may have then become too late for them to be treated. So it's really quite important that we stress to our primary care and our emergency care colleagues that this is in fact one of the rare otologic emergencies for which they should be sent to us quickly. So the second key action statement talks about modifying factors, and it says clinicians should assess patients with presumptive sudden sensory neural hearing loss for bilateral sudden hearing loss, recurrent episodes of hearing loss, and or focal neurological findings. Again, this is not there for idiopathic sudden hearing loss, and this goes down a different treatment pathway, whether it's bilateral, recurrent, or fluctuating, or if there are neurological findings. So this is an important thing that you assess at the time that you see the patient. So the patient is now coming to the emergency room or the urgent center. He has sudden hearing loss. What test should we not order in the emergency room? So I don't know what happens in England, but in the United States, it's a knee-jerk reaction in the ER to order a head CT scan, which are those thick cut head CT about 5 centimeter cuts through the brain, which essentially show you nothing, cost quite a bit, and give the patient exposure to radiation. So we are very strong recommending against the ordering of routine CT of the head in the initial evaluation of the patient with presumed sudden hearing loss. Now, if they have a neurological finding, if there's some other reason to do a head CT, certainly you should. But unilateral sensory neural hearing loss alone should not be evaluated in this manner. So this is what I'm talking about, these very thick cuts through the brain that really tell you nothing. I am not saying don't get a temporal bone CT scan if you think that that is needed. So a temporal bone CT may show enlarged vestibular aqueduct, as you see in the top picture. It may show superior canal dehiscence, as you see in the bottom two pictures. So that is something that you would do usually at a later time than at the first initial presentation. So what tests should be ordered and how soon should you order them? So you should get an audiogram as soon as possible and within 14 days. And the reason, there was some discussion when we added the within 14 days, because I practice in a big city. I practice where there is audiometric capability. But if you're rural, if let's say it's a pandemic, if there's some reason the patient can't come in, we would like the patient to be able to be assessed with a proper audiogram at least within 2 weeks of onset. The inability to get an audiogram should not preclude institution of treatment. So that is really important. You don't delay treatment because for whatever appropriate reason you're not able to get an audiogram. Now, what we found during the pandemic is that we're able to use apps on our phones. The World Health Organization, the WHO, has a very nice app. Mimi is a good app. There are a couple of really nice apps out there that are either free or very inexpensive that the patient can use to essentially give themselves an audiogram in a quiet room in their home and send that to you if the only way they can be seen is through a virtual visit or if there's no other resource available for them. So let's talk about the shape of the audiogram, because this is where we get to trying to help the patient understand if there is a better or worse likelihood of their recovering with or without treatment. So again, that Fetterman study from 1996 showed that about 40% had sloping or normal low frequencies sloping to hearing loss in the high frequencies. So about 40% presented with that. About 25 presented with a rising or low frequency audiogram. About 15% presented with a flat audiogram. About 9% presented with a U-shaped or cookie bite type audiogram, which is not shown here. And about 12% presented with anacusis, so with no hearing or profound hearing loss. And the outcomes for these are actually quite different. So if they have a rising hearing loss, like in audiogram number 1, where the right ear has a low frequency rising to essentially normal hearing, they have a tendency to recover. So low frequencies tend to do well. High frequency or a sloping hearing loss, which is the number 2 in the upper right, tend to not recover, particularly the very highs or the more severe. Flat losses, the low frequencies tend to recover more readily than the high frequencies, but overall the patient's sensation of hearing recovery is significantly better, even if only the lows come back very well and the highs only come back a little bit. And then if it's profound loss, like in audiogram number 4, that is described in the literature as anacusis or pantonal hearing loss. That has the worst prognosis. So we also talk not just about the shape of the hearing loss, but the degree of hearing loss. So mild hearing loss, almost all of them tend to recover no matter what we tell them to do. Profound has a very poor prognosis. And the moderate to severe hearing loss is sort of that 50 dB to about 75 to 80 dB cohort. They seem to fit into what Wilson, Beil, and Laird call the steroid effective zone, where there is a significantly better chance of getting better if you were treated with steroids 4 or 5 to 1 than if you were not. So what are other audiometric tests that we do? We obviously do word recognition score, and I was the chair of this guideline, and I don't think we put enough emphasis on word recognition because we know that even those patients who recover somewhat in their pure tones can have disproportionate loss of word discrimination that continues. And this may be due to cochlear synaptopathy and then some loss of cochlear neurons. So I think looking at word recognition is really, really important in these people. And frankly, even if I can only bring them up from, say, severe to profound loss to a moderate to severe, so about 55, 60 dB, but I can improve their word recognition so that they're getting 70 or 75% word recognition, those people become excellent hearing aid users. So it's really, really important when you're counseling patients to look at the pure tones and look at the word recognition scores. I don't know if otoacoustic emissions are very helpful. I think we try to get them to see if the hearing loss is not so bad that they would be absent anyway. We are looking at electrocochleography to look for this cochlear synaptopathy in silent hearing loss and the synaptic ribbon problem. I don't know if we're there. And ABR test really does not seem to help unless you're using it to rule out retrocochlear pathology. ABR test cannot be done if the hearing is worse than 80 decibels at 4,000 hertz. So if you're approaching that, then an ABR will be degraded and that will be a non-helpful test for you. So I talked about the app-based hearing test, and I just put up 3 examples here. So the Hear Who test is quite good, quite easy to use. The Hearing Test Pro is really quite nice to use. I think this one costs about $4 or $5 to download. And so if you have somebody with autoimmune ear disease that you're managing from a distance, this might be quite a nice investment for them. This is on the right in the green is the Mimi hearing test. It's pretty good. I have to say I tried out a bunch of these, particularly during the pandemic. I would ask patients to try to show me what their hearing looked like when I couldn't see them in person. And they were definitely better than me trying to guess. So what about blood tests? We always get blood tests. We're doctors, right? Wrong. Clinicians should not obtain routine laboratory tests in patients with sudden hearing loss. So this is that shotgun approach where you're going to get a complete blood count, erythrocyte sedimentation rate, all the metabolic panel, maybe some thyroid tests, some this, some that, some this, some that. So that's huge, where the vampire lab tech comes and draws, 20 vials of blood. There's no data supporting this sort of shotgun approach to laboratory testing. However, if you think that this is not idiopathic, but may actually have a cause that you can identify, it is worth getting those labs. So this is a tick being pulled out of skin that has a bullseye rash around it. So this is the Borrelia that causes Lyme disease. So in the Northeast of the United States, we are endemic for Lyme disease. There are other areas in the United States that are endemic for Lyme disease. I'm Indian, so I don't go outside, but a lot of people go outside and are picking ticks off of themselves a lot. So if they report that they had a bullseye rash, or they may have been exposed to a tick that they didn't even notice, or they pulled a tick off of their dog the last time they went for a walk, I think it's worthwhile drawing Lyme titers on them. I put in the second slide because Lyme bullseye rash looks significantly different in African skin than in white skin. So Caucasian skin has a very clear bullseye looking thing on the right of the second panel. The African skin type, you really can't tell. You can kind of see that something happened, but you really have to look closely to see that this is in fact also a bullseye type of rash. And this is actually from a paper that was written by a she may have only been a second year medical student, Lash Nolan. She's at Harvard Medical School. And she realized, she happens to be African American, she realized that all of the skin lesions that were being shown in Caucasian skin. And obviously, skin lesions look different in different colored of skin. So this article actually appeared in the New England Journal of Medicine with the title, I think the title is, "Are We Missing the Bullseye?" And I think it's very important that we, hearkening back to my talk to you guys from December, let's talk about including all of our patients when we're describing what things can look like. So we are seeing a rise in syphilis in the United States. So we're seeing a significant rise in both primary and secondary syphilis cases, 14% increase between 2017 and 2018. We're seeing it in the gay male community. We're not so much seeing it in the heterosexual community, but we're also seeing gonorrhea and chlamydia, which we are seeing in the heterosexual community. So before the lockdown and before anybody saw anybody, we are seeing this increase in sexually transmitted diseases, and syphilis can mimic Meniere's disease. It can mimic that low frequency sudden hearing loss, and certainly the treatment, if you can prove that this is syphilis, is also to treat with penicillin. So what about COVID-19, the vaccines, and sudden hearing loss? So there is really no link between any of these things and sudden hearing loss. There have been a few sporadic cases of COVID-19, sudden hearing loss within 2 weeks of having COVID, very sporadic. Same for getting the COVID vaccine. Having said that, I will tell you that my husband developed this very big baffle sound, like of tinnitus, about a day or two after getting his second dose of his vaccine. I think he got Moderna. And he had a low frequency hearing loss on audiogram, and I was able to treat him with full recovery. So I think that was caused by it. The treatment ended up being the same, but I think we need to always be aware. I always ask people. For a while there, when I was seeing people with sudden hearing loss, I actually did PCR testing on them to see if they had COVID, and they were all negative. So I don't think that that relationship is very good, but when it happens, you should be aware of it. What about retrocochlear pathology? So key action statement number 6 says clinicians should evaluate patients with sudden hearing loss for retrocochlear pathology with an MRI scan or auditory brainstem response, and we removed serial audiometry from one of the choices. If the patient can get imaging but cannot have an MRI, they have a pacemaker, let's say, they can certainly get a CT scan with contrast. So we prefer full brain and IAC MRI with and without gadolinium. You can get a T2 fast spin echo MRI, which is non-contrast, which is significantly less expensive and can be faster. And then if you're getting a CT scan, so if you're getting an MRI, you're obviously looking for this lesion here, which is a vestibular schwannoma. If you're looking at this CT scan here, you're seeing a normal IAC here. This is a non-contrast image. And then you're seeing this widened IAC here. So you see the significant difference between the two sides. What about a patient with sudden hearing loss who recovers their hearing? Do they need an MRI as well? I will tell you, many of my colleagues say no, and they would be wrong. Yes, everybody needs an MRI, or everybody needs a retrocochlear workup. The only time I really would not, and I would say, okay, let me just watch you for a while, is if they are quite elderly and there's no intervention that we would even contemplate for a small vestibular schwannoma. So remember that vestibular schwannoma prevalence is significant in sudden hearing loss. So 10 to 20% of people with a known vestibular schwannoma or acoustic neuroma give you a history of sudden hearing loss in that year, with almost a third of them reporting improvement. And if they were treated, 50% improvement. So improvement doesn't tell you anything. And then many of them had an intercurrent upper respiratory infection, or maybe a tick bite, or something that you could say, oh, that's your cause. So there's no significant effect of treatment type, audiogram, electrophysiographic findings, or tumor size. And in patients with sudden hearing loss, we see overall abnormal findings between 11 and 31%, which can be a vestibular schwannoma or a meningioma, but can be some other multiple sclerosis. Is unfortunately sudden hearing loss is the first diagnostic criteria. So there are other things you're looking for other than just a vestibular schwannoma. So let's talk about patient education. So this is like, it feels very soft, but I'll tell you, this is very important. Clinicians should educate patients about the natural history of the condition, because we do see some spontaneous recovery, the benefits and risks of medical interventions, and the limitations of what we know regarding efficacy. So it's really important to take the time to talk to your patients and allow them to express their concerns and their questions. So Andy Capp is one of my favorite cartoons, and I love this. What is shared decision making? The doctor says, the best thing you can do, Andy, is to give up smoking, drinking, and fried food. And Andy says, okay, what's the second best? And I think that's where the shared decision making starts. And then it comes to a conclusion somewhere where Andy may not be giving up everything, but he may be minimizing it. The doctor may be willing to accept some compromise for the patient to get better within his environment. So let's get to treatment. I've been talking. Let's get to treatment. So let's talk about initial corticosteroids. Everybody gives people initial oral steroids with sudden hearing loss. There are a couple of non-treaters, but most people will give steroids. However, the data does not support this yet. It is an option. So they may offer corticosteroids as initial therapy within 2 weeks of symptom onset. Again, we're having that timing. So this is where the timing of presentation is very important. And this is an option with a new randomized controlled trial or two that shows possibly some benefit. And then there's a balance between benefit and harm if the patient has no underlying issues. Once we published the initial clinical practice guideline, because it was still an option then, I think that enabled people to feel it was ethical to do randomized trials. So I think we do need more of these to see where steroids fall into our armamentarium in the initial treatment. So if you're using initial corticosteroids, please don't undertreat. So either treat or don't treat, but don't undertreat. Or, as Yoda would say, undertreat, do not. So this is a Medrol dose pack with an X through it, and this is a very, very small dose of methylprednisolone that's delivered over 6 days, rapidly decreasing dosages with the first dose on the first line and the last dose on the single thing on the last line. The correct dose is, if you're using prednisone, 1 milligram per kilogram per day for 7 to 10 days, followed by a taper. Dexamethasone can be used in an equivalent fashion. I find that in my experience, patients get much more headaches and just discomfort in their treatment course when they're given not prednisone. They do pretty well on the prednisone. You do have to cover if they have propensity to GERD, and Dr. Aviv, my colleague, would say you always have to cover for acidity. You have to talk to them about they may be emotionally labile during the time that they're on the prednisone. and their skin will be more sun sensitive, so that they should be wearing sunblock if they're outside. What about hyperbaric oxygen therapy? So statements 9A and 9B refer to initial and salvage therapy. Initial is within 2 weeks and salvage is within 1 month for hyperbaric, and it is still only an option, and it's only an option if offered combined with steroid therapy. So hyperbaric oxygen alone is not recommended. Hyperbaric oxygen with steroid therapy is an option, only an option, not a recommendation, within 2 weeks or within 1 month of onset. What about intratympanic steroids? My husband thinks this is the only thing I know anything about, and he's probably right. So intratympanic steroids are a direct application of the medication via a small hole in the eardrum onto the round window membrane, where it can then cross that semi-permeable membrane and get into the inner ear. You can avoid systemic side effects, and in animal studies by Lauren Parnes and his colleagues, and then by me, and then by Jim Saunders and by others, we are showing significantly higher perilymph steroid levels when the medication is delivered transtympanically as opposed to systemically. And you can see that in Parnes's data, intratympanic steroid was better than systemic for the inner ear. And in his data, methylprednisolone had the highest concentration for the longest time in the inner ear compared to dexamethasone and hydrocortisone. Now, again, methylprednisolone is more difficult to administer. It burns when you give it. It really burns. So people either have to be quite hardy, or people are mixing it with lidocaine, which I find to be strange because lidocaine can cause some ototoxicity and can make you vertiginous. So I actually use dexamethasone, and I use 24 milligrams per ml, which I have compounded for me at a pharmacy, because in the hospital, the max you can just pick up off the shelf is 10 milligrams per ml. So this was my study that was published in 2001. We looked at 40 guinea pigs, 79 ears. We saw that the red, the intratympanic dexamethasone, was significantly better than the systemic, which is in the first blue. When we tried round window facilitators, we found that hyaluronic acid, which is in sort of this neon blue color, did better than just steroid. So this was HA with steroid. And then histamine was a really potent facilitator, did much better with the steroid compared to the steroid alone. And then that was attempted to be monetized, and they did something went wrong with the studies. And I think they're coming back and trying to look at that again. Somebody else. I didn't patent it, and I don't have any say in it. So Jim Saunders at Dartmouth looked at 10 guinea pigs, and he looked at delivering the dex in hyaluronic acid gel, and he showed that in the red bars in the bottom, in the blue bars were just steroid, and the red bars is the steroid in the gel. And you can see that the steroids were higher level in the inner ear, and then lasted for significantly longer in the perilymph than when given without the facilitator. So I think there's still going to be a role for facilitator. Anil Lalwani is looking at micro perforation arrays at the round window to see if that can help facilitate transport. So there's quite a bit of information being gleaned in this space still. So what about salvage therapy? So we said it's an option for initial therapy, but in fact, we have a recommendation that the clinician should offer intratympanic steroid therapy when patients have incomplete recovery from sudden hearing loss from 2 to 6 weeks after onset of symptoms. And that initial therapy may have been nothing. So even if they show up late, they show up at 4 weeks, we call this now a salvage because their initial therapy was observation and it didn't get better. So we have observation. It could have been oral steroids. It could have been intratympanic steroids. It could have been plus or minus hyperbaric oxygen. It could have been whatever else you decided to treat the patient with. This is a cartoon showing the injection. Nobody is using a 10 ml syringe for this. You should not be doing that. One, that would be crazy. Two, that would really hurt the patient because the pressure behind a plunger of a 10 ml syringe is ridiculous. And the middle ear holds between 0.3 to 0.5 ml of the fluid that you give. So I use a 1 ml syringe, I draw 0.5 ml of the solution, and I inject it. And I'm going to show you my technique in a second. So this is a left ear that's going to be injected. I have the patient lying back in sort of that otologic position with the ear to be injected facing up. My target is the round window membrane, which is here, those oval shape here. I take my 1 ml syringe. I have a long spinal needle on it, which I use a 22 gauge spinal needle. One of my colleagues is using the, I think it's the Terminate injection needle of the Intellis system. She likes it better. You know, spinal needles are easy to get. I draw 0.5 ml of the, I use dexamethasone 24 milligrams per ml. I touch the anterosuperior portion of the drum with a drop of phenol, and I do it in a phenol applicator, which looks it looks like a right angle hook, but it has two ends to it. So the phenol only is between the tips, and you just touch the drum. It burns like crazy for a second, and then it's done, and it blanches once it burns. Then I make a superior puncture with the tip of my needle, and I make an inferior puncture through which I insert the fluid, which then fills the middle ear space, air bubbles, and then fluid come out of this top one, and I'm done. And then I have them sit there for 20 minutes to bathe the round window. A patient of mine who drinks a lot brought in a cork one day and said she realized if she keeps her teeth the width of a cork apart, her tongue doesn't touch her palate, and she doesn't want to swallow, so I don't drink enough wine. So I make a cork like this for the patient, and they're pretty comfortable as they're lying there. And if they swallow, you overfill. And with that position, you are really bathing the round window for far longer than you think, which I think is very nice. So I made a little video. Hopefully this will appear. Right. So what are the questions we still have? We don't know which is better. Like I said, I use dexamethasone. I don't combine it with anything because nothing's available right now, but you can use methylprednisolone. I use 0.4 to 0.5 ml of 24 milligrams per ml. I think 4 milligrams per ml is pointless. 10 milligrams is okay. My outcomes are significantly better with 24. For Medrol, you see what's listed there. There is definitely evidence for some facilitators. I do this once per week for 3 to 4 weeks, and I get a hearing test each time, and I stop when the hearing has improved satisfactorily, or if there's no improvement after 2 or 3 injections. And I will also ask them, they'll sometimes say, oh, my hearing got so much better midweek and now it's gone down again. To me, that's an active ear, and I will keep chasing that recovery. There are different techniques you can use. I just showed you mine. And when is it too late? So I have done, you know, in American football, they call it a Hail Mary pass. There's 1 second left on the clock, and all you can do is try to throw the football all the way across the field, and hopefully it's caught in the end zone for a touchdown and your team wins. So that's a Hail Mary pass. So I am a bit of a Pollyanna. I really want to believe that people will get better, and I will offer people sort of salvage treatment outside of the guidelines. up to probably 3 to maybe 6 months later, but after 6 months, we're not showing any improvement at all. If it's delayed like 2 months, 3 months, 4 months, I'm often able to get that word discrimination up and make them a hearing aid user, which really positively affects their quality of life. So I think you still have to be a doctor, and you still have to see the patient in front of you and see what it is that they need. So when the patient cannot take systemic steroids, like the brittle diabetic, the bad hypertensive, the person on blood thinners, is intratympanic injection okay? And Steve Rausch ran a multi-institutional trial, which was a non-inferiority trial looking at oral versus intratympanic. And not only is intratympanic non-inferior, but it has significantly fewer side effects overall than the oral steroids. So it is a very, very good choice when you feel you cannot give oral steroids or you don't wish to give oral steroids. And then these other papers showed very similar outcomes. What about other pharmacologic therapy? So we said very strongly should not routinely prescribe antivirals, thrombolytics, vasodilators, or vasoactive substances to patients with sudden hearing loss. In the update, we actually removed antioxidants from this list because there's some data regarding antioxidants. It's not great, but it's not a should not. But in reality, a lot of people use antivirals, carbagen, antihistamines, beta-histine, papaverin, and N-acetylcysteine, which is an antioxidant. So, you know, there's the guidelines and then there's reality. I think if it's a relatively safe agent, look at your own data. It's really important to look at your own data, the data of people in your area, and try to figure out what is the best you can do to try to help this person recover a lost cranial nerve, frankly. What about outcomes assessment? Obviously, we should care about how they're doing. So we should obtain follow-up audiograms at the conclusion of whatever your treatment is, whether it's oral, intratympanic, salvage intratympanic, hyperbaric, papaverin, whatever your treatment is, and then 6 months later. So you want to look at them at the conclusion of your care, and then 6 months later. And if you want to look at them in the middle, at 3 months, you can. Wycherly showed that audiograms may not show improvement until about 5 weeks later. So you really do want to keep tabs on your patient. And then we need some help defining what hearing improvement is. Do we look at absolute hearing improvement? Do we look at relative hearing improvement? Does that 50-50 rule of 50% speech discrim and 50 dB hearing for a usable ear really apply? I'll tell you, 50% discrim does not do as well with a hearing aid as like 65 or 70%. So if we can even get them up to there, that's a significantly enhanced quality of life. So is it worse to go from deaf to profound hearing loss, where now they have this weirdly active ear and they're not just absent of hearing? And what about tinnitus? So we mentioned tinnitus in this guideline. We have a really beautiful clinical practice guideline on tinnitus that I recommend that you go through. But you know, this can be a really frustrating part of the process for them, and we can see tinnitus that remains even if the hearing is improved, possibly because of that synaptopathy problem that was identified. What about rehabilitation? We should counsel patients with residual hearing loss and or tinnitus about audiologic rehabilitation and other supportive measures. So talk to them about cross or contralateral routing of sound hearing devices, or bicross if they need amplification in the good ear. Talk to them about osseointegrated implants like the Baha or Ponto Pro, or this is the Ossia implant from Cochlear. Talk to them about cochlear implantation, because single-sided deafness people do very well when their deaf side is implanted, even if their good side has normal hearing. So these are all really good options for them. I gave a lecture in my last lecture away where I got to fly somewhere before the pandemic was up to Syracuse University in New York, where my son was completing his college education. So I got to see him too. and they somehow checked me into a hearing impaired room. Maybe they know something about me, I don't know. But this is what the label said. And what happened is when you ring the doorbell of this room, the lights flashed and the sound was really loud. But it's, there's some really interesting assistive listening devices that we can encourage our audiology colleagues to talk to our patients about. So what about these implants? So these are questions, if you want to have me back, or I can recommend another speaker to talk about when we identify what type of implant we wish to offer to these patients and what are our expected outcomes. I think that's an entire lecture in and of itself, but these are the questions you should be asking yourself as you enter into the shared decision making that will help the patient get better. And then I'm going to stop here. So there's a lot of research going on. I'm just going to show you this. You can go to clinicaltrials.gov to see what are the National Institutes of Health in the United States approved, FDA approved trials for sudden hearing loss, for autoimmune ear disease. What are the active trials going on? And they include AM111, prednisone versus dexamethasone, anakinra, rilonacept, and FX322, and I think there's some very interesting stuff going on there that I strongly recommend you look at. And I want to thank you for inviting me, and I'm happy to take any questions.
So I'll start off with a question of my own. This is what the clinical practice guideline is, but does your personal practice differ in any way from these guidelines?
Yeah, so I will treat later than the guidelines recommend, because there is a delay in coming in sometimes. I will sometimes I add papaverine as a vasodilator these days, and often I'll do that for the more severe to profound hearing loss patients. Again, that has to be bought at a compounded pharmacy. It's a little difficult to get. I've not seen data about beta histine, which is easily available there, but not here. You have to send away to Canada for it. In profound hearing loss, or nearly profound hearing loss, I will actually, so if you want to know what I normally do, I will see you, I'll counsel you, blah, 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 blah. We'll come up with a plan. Usually I will treat with the high dose prednisone for 1 week. And as they start their taper, I will see them back. And if the hearing has improved, well and good, and we're happy, they finish their taper, and then they come see me in about maybe 6 weeks, and then 6 months. If their hearing is not improved or not adequately improved, I will offer them injection series starting on that second visit. And it gives me a chance to explain what the injection is to them the first visit, if they need to bring somebody with them to drive them home, because they can be a little bit dizzy afterwards. Usually doesn't happen where it's long lasting, but of course, my colleague injected one of my dear friends in Washington, D.C., and she was so dizzy that he had to drive her home. So it can happen. But so I will start that process if their hearing has not recovered. And as they taper off the oral steroids, I'll be doing my once weekly injections. If they have if they have like nearly profound or profound, the data from the Kaiser Permanente group, Bob Cuevas group, is actually quite good about doing everything at once. So oral steroids and intratympanic steroids, and I might even add papaverine at that time, all to begin at once in terms of recovering these people who have a very poor chance of recovery otherwise.
So you'd basically consider concomitant use of oral steroids and intratympanic steroids mainly in profound hearing loss patients, is that right?
Yes,
okay.
Yes, because I don't think we're losing anything by trying the non-injection method in other cases. If the patient has, of course, a condition where I can't give the oral steroids or preferable not to, then they're pregnant, whatever, or they're about to have their COVID vaccine, right? They can't be on steroids for that. I will do the injection. as the first line.
And how many injections would you usually tend to give before you decide to stop?
So I will tell the patient I normally will plan to do 3 or 4 injections, anticipating that the hearing will recover in that time frame. If there's movement continues after 2 and 3 injections, either subjectively or objectively, I'll just keep going. I think the downside to injections, the only real downside is a persistent perforation at the site of the puncture. But if you do that properly, my rate of persistent perforation is less than the rate of AstraZeneca vaccines causing blood clots. But I would say, you know, I'll keep going if they're still improving.
Right. I'll go back to the questions again. You mentioned that there's a differential recovery rate based on the, that's been seen based on the audiogram slope as well as the degree of hearing loss. I mean, is there any explanation that we have for that at the moment?
So we think, so the high frequencies are just more sensitive to everything, right? So noise causes high frequency hearing loss. Most toxins cause high frequency hearing loss. Aging causes high frequency hearing loss. So we believe there's a vascular component to that. It may be that the intracochlear artery comes in and then branches out, and that may be sort of in the last branches of that intracochlear artery. And low frequencies possibly are the first presentation of Meniere's, which famously has recoverable hearing loss for a long time in the initial course. So Norma Penido from Brazil, not one of these weirdos posting fake Brazilians, but she's a real Brazilian. She's from the Federal University in Sao Paulo, Unifesp. And she looked at sudden hearing loss patients over and followed them for a year, a large cohort. 30% manifested fully as Meniere's in that time. So I think the low frequency loss people are really very Meniere's-like and are treated a little bit differently. So they may end up with, you know, diuretic, they may end up with beta histine, they may end up with low salt diet, hydration, etc. Whereas the high frequency are a different group of people. I hope that was useful. I don't know. I kept talking.
No, absolutely. And that makes sense as well. That sort of feeds into a question that I had as well. So would you treat patients with acoustic trauma in a similar fashion to sudden sensory hearing loss?
So the short answer is yes.
Okay. And
the long answer is there's some really good clinical data from the armed forces that noise-related acute onset tinnitus responds quite nicely to N-acetylcysteine treatment. So if there's a measurable hearing loss, I will treat like a sudden idiopathic sensory neural hearing loss. But because there's a noise component, I will add NAC, which comes as either 500 milligram tablets or 600 milligram tablets. And the dose for acute noise-related tinnitus is 2,000 milligrams twice daily for 2 weeks, followed by 1,000 milligrams twice daily for 2 weeks. And then they can just stay on a single 500 if they feel like it. But if they give a clear noise exposure, I will add the NAC to what I'm doing.
That next question that we've got is from point of view of radiology, cross-sectional imaging. Would you do both CT and MRI, or would you just do an MRI?
So if you're only looking for vestibular schwannoma, only do an MRI. And some guy came to my office the other day. They can do a full brain IAC MRI in 9 minutes in their facility. I don't really even understand it. But if you're looking for vestibular schwannoma, the gold standard is MRI. If you think that it's something unusual and you're looking for superior canal or vestibular aqueduct or something, then a CT is obviously indicated. And before cochlear implant, I have to say that I've been doing both MRI and CT before cochlear implantation.
Okay.
I'm an old dog, that's it.
I think you already answered this question. If it's a delayed presentation, would you still consider giving oral steroids? You mentioned that you would tend to give treat patients beyond the initial 2 weeks as well. Is that correct?
Right, but my counseling is different. So this is where that key action statement 7 sounds so crazy, but it's actually really important, right? Make sure that they understand what you are thinking, so you don't want to set unrealistic expectations on the, terrible off chance that some untoward event occurs. You want to really have talked about, the guidelines say this should have started, within 6 weeks, but this is what we're going to do because this is when I'm seeing. And I think it's very, very important for the patient's outcome to engage them in that dialogue. There are also, I have to say, every single clinical practice guideline has a patient summary. They have a full guideline, which is usually about 30 pages. They have the executive summary for doctors, which is about, I don't know, 6 or something. And then there's a patient education summary, which is very written in language patients can understand. And certainly you can go to the American Academy of Otolaryngology Head and Neck Surgery website, which is entnet.org, and you can print out or send your patients there for that patient-related information. We have a whole patient-centered part of that website where they can find out a lot of evidence-based answers.
I think I just skipped one question by mistake. One of our attendees today asked, how sensitive is the Weber or the Rene test in clinic for discerning conductive and sensory hearing loss? And is this something that you would still recommend?
So if it's 25 dB or more of a conductive loss, they're extremely efficient to diagnose that by Weber and Rene. If it's less than that, you may have difficulty doing it. Sometimes I'll ask the patient to go like this, and ask if they hear that more in one ear or the other, because the autophony and even milder conductive hearing losses is a little bit more. So it's not ideal, but it's certainly ideal to rule out conductive and get the patient with proper institution of care for sudden sensory neural hearing loss.
Perfect. Well, what are your thoughts on removing the false membrane of the round window for better in-ear steroid action? That's another question.
It's an excellent question. So for a while that was very, very popular. I must say, it was extremely popular in people who owned their own surgery centers. I'm just going to say that. But so I did it a couple of times. Because it was also spoken about by people for whom I hold a great deal of respect, like Dennis Poe. I did not find that those false membranes are thick enough or comprehensive enough to prevent the entrance of the stuff I injected to oppose the round window membrane. So I do not think that there's really a role for that, unless like your imaging shows some thick adhesion or something and you want to try that. Okay. Dennis talked about doing like a posterior inferior radial myringotomy and then putting a small narrow endoscope in and then lysing adhesions that way. So it's not really raising a tympanomeatal flap, and then putting in some gel foam soaked with the steroid that way. I don't think the outcomes of any of those were found to be any better than injecting in the office.
So the question was that for intratympanic steroid injection, why is it that we are only recommending it for a salvage treatment and as an option for first-line treatment? Is there?
Yeah, it's all based. So this is all about systematic literature review. So there is not enough literature to show that either intratympanic or oral steroids, systemic steroids, are beneficial as an initial treatment, but there's plenty of really good studies with controls showing that the salvage is beneficial with intratympanic. So it really has more to do with the paucity of literature than science of intratympanic injection.
Perfect. I think for last question is about, would you please explain your technique of intratympanic steroid injection again?
Yes. Do you want me to show the video while I
I think
talk?
that probably makes sense.
Hope I'm not making you dizzy. Okay, so I'm gonna show it. I'm gonna talk to you here, and then I'm gonna show the video again, if that's okay. Okay. So I have the patient lie back like so. They're about 60 degrees back. Their affected ear is up. Obviously, you take the cerumen out of the ear. I touch the anterosuperior portion of the drum with that phenol applicator that you saw. So the phenol applicator has been dipped in the phenol, and really there's only that micro drop between the tines of the applicator. That touches, so be very careful, don't touch the ear canal, because it really does burn. And I wear gloves because I don't want my fingers to get burnt. So touch it and go away, and warn the patient, this burns like crazy for a second. It's like that. Once it's blanched, it's done, whether the patient has felt the burn or not. Then I take my 1 ml syringe that's about halfway filled with the solution. I take a long spinal needle, you can see it here in this picture, and I bend it like an ear instrument. And then I make 1 puncture superiorly, and then just below, this is inside the white of the blanch of the phenol, and then immediately below that I make the 2nd puncture, and through that I start injecting, and I see the fluid, literally I see the air fluid line fill like this, then air bubbles come out the top one, and then fluid comes out the top one, and I'm done. Sometimes they're dizzy. If they're vertiginous with this, I like it, but there's no proof that that helped. I ask them to open their eyes and fixate on a point, and then they just lie there for 20 minutes. So then here is the videotape. You can see how white it is there, and they really don't feel anything. Hope that was helpful. Boy.
That's brilliant. I had a few questions of my own, I think. From point of view of speech discrimination and the word discrimination scores that you mentioned, that's an interesting point because it's not something that we, at least in the UK, routinely do for patients with sudden sensorineural hearing loss. From point of view of the timing of the test, do you usually do it along with the first pure tone audiogram, or is it something that you do at a later date?
No, I do it with every audiogram. So for me, a complete pure tone audiogram is pure tones, air and bone, obviously if there's any sort of air bone gap, and then word discrimination score. And then the tympanogram is actually less useful to me, but the pure tones and the speech are really very crucial. And I will follow both with the patient because I'll often see that 30% speech becomes 42%, becomes 64%, as their pure tones start to come up.
And so just anecdotally speaking, how often do you tend to see an improvement in the speech discrimination, but no improvement in the actual audiogram itself?
Anecdotally, and it's only anecdotally, it's when the presentation is late, somehow the pure tones kind of get stuck where they are, but I can enhance the speech somehow. I don't really understand why, but it takes them from really a non-hearing aid or poor hearing aid user to a good hearing aid user.
Perfect. I think that's effectively all the questions we've got. I think just one last question has come up at the moment, talking about repeating the therapy that you use for acoustic trauma with N-acetylcysteine.
Yes. So let's say it comes as 500 milligram tablets, because it does. So it's 4 of those tablets. So it's 2,000 milligrams twice daily for 2 weeks. Then 1,000 milligrams of 2 tablets twice daily for 2 weeks. And then they can stop, or they can just stay on the 1 tablet for a while until they get bored. So it's basically 2,000 milligrams BID for 2 weeks, then 1,000 milligrams BID for 2 weeks.